Right, to welcome. Yes, I'll hand over to you, Mike, to introduce and welcome everyone to this webinar.
Well, good afternoon. I suppose it's just about good afternoon by about 3 minutes. Good afternoon, everyone. Welcome to this webinar on procurement. We're pleased to have Keith Young, who's going to do the presentation. He's from Health Partners. He's been involved in occupational health for I think 15 years as a business development director, and he's worked for a number of providers before, Health Partners. He's also traveled a lot in Africa and lived in Africa for a while. He'll probably tell us all about that. What we're trying to do, I think, which I think will be very interesting, is talk about what to do when you're trying to procure, because many of us, I'm sure, will agree that it's quite common that that in the commercial industry we spend a lot of time on procurement, and it can be quite difficult, particularly when, and I think Keith will smile on this, but when you're dealing with procurement operatives who really have no idea about occupational medicine or occupational health. They know how to do procurement, but they don't know anything about what we're talking about. So hopefully Keith will deal with that later today. We're going to be here for an hour. We will hear from Keith, and then towards the end, I'll take questions from everyone, and Keith and I will help with the questions. That's the idea. So Keith, over to you.
Thanks, Mike, and thanks for the opportunity. And I think, as Mike has said, the intention that I was really coming from this today was to give a view from a provider, a supplier of the sort of lessons and messages we wanted to get across when you're going through that process of procuring occupational health. And I apologize for some of you, this might be seen as Occupational Health 101, but I think it is important just to stand back and understand exactly what is being procured here. And I think the best way I can describe it is occupational health is a professional advisory service. It's there a bit like you'd acquire legal advice. It's there professional clinicians giving their qualified opinion on various issues relating to the impact of health on work. It used to be in the old days work on health, when it was dangerous to go to work in the old days, mines. Obviously we're now, and we've just seen that over the last 3 to 4 years, the huge impact that health can have on the ability for people to work. Now, I know the Society produced a great value proposition document, and that's out there and well worth a read. It'll go into a lot more detail. But effectively, what I like to do is group it into 3 key areas. One is what I call health risk management. So trying to understand the health of your employees right at the outside, from pre-employment or during their work period. And occupational health hygiene really sits within that gambit. Health management support, when there's an issue, somebody's at work, you need professional advice, or they're off work, you need professional advice, what we would call management referrals. And then the prevention side, which really should be first and foremost, but is increasingly being discussed, the health and well-being element. And we're starting to see as well that because of the requirement of organizations, there is a sort of a broadening of that agenda into more primary care support, supporting healthcare trusts, and we're seeing a lot of interest and increase around the sort of whole neurodiverse side. If I'm going to deviate very slightly just to set the scene, because I personally believe that not only is occupational health obviously very important at the moment, but I actually think organizations are going to need more and more of this type of support, with some of the known and what we predict forthcoming challenges are coming down the line to you. So there's a whole raft of issues that are affecting your employees, and some of them are the obvious ones: the aging working population, obesity, those sort of things. Smoking's declining, it's still there, but I think some of the newer ones actually are where the real driver is going to be on increasingly providing health support to organizations. And that is a sort of spin-off from the pandemic. You could argue some of it was there before, whereby the ability for individuals to access primary healthcare support in the UK is becoming increasingly difficult. We know already the waiting lists are significant in this country, 7 million, well, one of the highest in the developed economies in the time it can take from an individual to get primary care treatment. And this is all trying to support a workforce that it's already working in slightly different working practices than perhaps we all did up until early 2020. And we're starting to see already some of the effects of that. And I think there's been some very alarming statistics that for years, long-term sick was slowly reducing or at least staying static. But we're starting to see significant increases in that. And I think it's quite obvious that that's symptomatic of people struggling to get primary care support. Indeed, I ran a slide just on our own numbers that we have in the organization. We look after around, I don't know, 7,500 referrals a month. And what's really interesting here is traditionally a proportion of cases are mental health cases, which is this rather strange orange stroke pinky section at the bottom. You then have musculoskeletal. And what's interesting to me is this dark blue line, which has been increasing really since about June, July last year, 2021. And this is all the other, not traditionally grouped as mental health, not traditionally grouped as musculoskeletal. It's the other cases. So it's the cancer treatments, the gastrointestinal issues, etc., that are affecting ability for people to work to their full capacity, and hence organizations are starting to refer more and more of these types of cases through to occupational health. I think that's to me, it was a very clear graphic illustration of the numbers that of increasing people struggling to get primary care support. So if I sort of take a step back from the picture as it is and what's coming down the line to employers, and just look at the occupational health market as a whole. As with a number of markets, there is sort of constant change within the market. We've seen a number of consolidations going on at the moment from either organizations bringing together a couple of occupational health providers, to others that are focused very specifically in the occupational health industry. So a number of years ago, there were insurers that offered occupational health, and most of those have withdrawn from the market because it's a very specific market. So that consolidation has sort of occurred. And what you're seeing out of that is that there are a few what I would call national providers with directly employed clinical teams. And you could argue whether that's 4, 5, 6, etc. But those are the sort of larger occupational health organizations. There are some regional providers or what I would call specialist providers that focused on specialist areas. And then supporting all organizations is this broad range of independent clinicians that can operate on their own, but they form part of a sort of network of contractors. And what's really interesting looking at this is traditionally occupational health, a large proportion of it was done face-to-face. Obviously, online technology has changed some of that, and the pandemic transformed the way occupational health is provided because people couldn't be seen face-to-face. And actually, a proportion of the work that can be done remotely, and when I mean remotely, I'm talking about telephone video consultations, are being delivered on that basis. And actually, I think there was an acceptance that it worked. It continued. The quality of advice didn't deteriorate because it was being given either over a telephone or video consultation. So this sort of network of face-to-face contractors that everybody used to sort of wave the flag of, I think has diminished in its importance, and it more now relates to the most appropriate clinician being able to support an issue as and when it occurs. The other thing, like all health sectors at the moment, there is a shortage of occupational health clinicians. We're not going to solve that overnight. It's an ongoing issue, I think, that challenges the industry, but it challenges the whole health sector. And whilst various organizations will come up with ideas to try to plug that gap to increasingly train clinicians and increase them, we just do need to recognize, or you as a buyer need to recognize, that there is a shortage of clinicians, and that's the factor we need to find a way of working around. So if I was to sort of move on to the focus, therefore, of what I think as a buyer you should be looking at in trying to define your requirements to get occupational health support. Obviously, it goes without saying that every organization has slightly different needs. Not only does size slightly dictate it, but I think critically health risks dictate it. So an office-based organization will have a invariably lower health risk than a manufacturing organization, where people are exposed to a potentially broader range of risks. And hence, out of that, there is a sort of slightly broad range of services, and I'll come back to that. The other thing, and going back to my point on the sort of changing health profile, you know, my strong recommendation, and I'll mention this a couple of times, is to procure services that are going to fit your requirements over the next few years, rather than just looking historically. You know, I do believe quite strongly that because the country as a whole is struggling to provide primary care support, that the increasingly pressure will fall on employers to support their employees that are having health issues. And therefore, you know, you need to be buying a service that is going to be able to support that as we come into the future. I also think it's really important, and I mentioned this right at the beginning, the health risks of your organization. And occupational hygiene undoubtedly is increasingly a requirement that organizations are using to not only identify health risk, but then monitor it as much as they can as they run through their operation. Because the ideal and optimum route for all of this is to reduce health risk and or improve the health of an individual. And you can do that so much better if you understand what the risk is and you're monitoring its impact on that. And then, you know, once again, coming back to this approach of a professional medical advice, you know, I urge really much that you treat this as you would, as I said, your legal advisors or other professional advisory services as a core partnership. I sort of constantly push against trying to treat this as a very transactional model. You know, we've got an issue, send it away, give us some advice back, and that's the end of it. I think there must be a much more open, trusted relationship so that any provider gets to know you as a buyer, your culture, your policies, how you work, your people, and the service they're providing is therefore much more bespoke and supportive of you as an organization. And once again, in those three pillars that I talked about earlier. And then supporting those three pillars, as I said, are a range of specialist services. I've talked about hygiene and neurodiverse, where we're seeing a significant increase, not only about helping shape your workplace, but also about providing advice to the organization on their workstation setup or how they operate in their workplace. And that can cover a range of neurodiverse conditions, but also drug and alcohol, vaccinations, travel health, and all the other sort of support services that go around helping an organization manage health in the workplace. And then the final thing, you know, when you're trying to focus on what you need, obviously service relationship is important. It's, as I said, very important you have this partnership relationship. You need to understand the clinicians working for you. And equally importantly, they need to understand you as an organization. And then there's an operational element. It all needs to operate smoothly within the SLAs that no doubt you'll set. And both of those, to me, should be the measurements of success, that relationship and how you manage it, the interface you can have with an OH provider, and the information they can provide is very important. So if we go on to some of the information that I would like, certainly as a provider, and I think the market would like to get, so that they can provide as detailed and as sensible a proposal or tender response to you. So some of the key information. Well, first and foremost, it's really important we understand you as an organization. not only who you are, what you do, but also lift the hood a bit and understand your sort of culture. How do you like to work with your employees? Some of your sort of core policies, the objective of the organization, how you're structured. I think, really, the more the better, because organizations will read through this and try to understand who you are so that they can provide as personalized a response as they can. Obviously, very important to understand your demographics, who you are, where you're based, and the more information, once again, perhaps even on age profile of the workforce can be helpful, but information on the workforce very important. And as I said, as much as you can on the health risks that your employees are subject to in the roles they're undertaking. We then need to obviously hear what you're looking for, and I go back to the 3 pillars I talked about. What health risks do you want to assess right at the beginning? Are you looking for hygiene support to understand what those health risks, pre-employment, or the ongoing monitoring of health during a worker's life? And that could be anything from statutory health surveillance, fit to work medicals, right up to their ill health retirement right at the end of their time with you. So the service requirements, as much detail as you can give, but by all means leave an opportunity to say, is there anything else a provider can offer you that you think will be of interest under those broad churches of the health support you're looking for. Always a challenge here, and particularly what we've seen over the COVID period. We like to know the volumes. It gives us an idea of the resourcing you're going to need. It also will give us an idea of the best models to come up with for you. So for each of the service lines, the more granular detail you can give us on service volumes, ideally the last 2 years, and I'm recognizing there that over COVID, that was really threw the numbers out. But if you can give as much information as you can on your actual volumes, and if you have that, your predicted volumes going over a period in the year. Your service objectives, what do you want to achieve from this? Is the focus purely about ensuring you're fully compliant on health risks? Is it about reducing absence? What are the core steps, the issues that are challenging you in the organization? But what I would say in setting those objectives, encourage innovation. I think the market is really good at coming up with new ideas of looking at health risks. To a degree, it's driven its own innovation over the years. And I just urge that you don't try to stifle that by being too formulaic. And I would say here, I know one of the challenges is procurement is trying to obviously set a very clear, fair benchmark so they compare responses. But at the same time, it's all about trying to come up with what's best for your organization. So I do urge that you leave as much opportunity for organizations to come up with ideas. SLAs, on the whole, we tend to see they are sensible, but every now and again you do get them that, they're just not sensible or achievable in the current climate. And I know everybody, wants to be as strict as they can around SLAs, but just recognizing the market, the shortage of clinicians, some of the challenges OH providers will work in, they'll come up with something because we are in a competitive environment that is, going to be sensible. But to me, there's no point in just coming up with unachievable SLAs. You'll either get a no bid response from an organization, or it's just not going to put you off in that great partnership route at the end. CUPE, obviously for the larger organizations where you might have an employee or a clinician that has worked that could fall under CUPE. Obviously the organization itself doesn't necessarily know that. Its provider, and more importantly, the individual in question, with the people who will understand CUPE. But I think it's a very fair question to ask a current provider if CUPE is likely to apply. And if it is, then any organization bidding would like to know the detailed information of who the individuals are and sort of their salary costs, benefits, etc. Or you can go down a route of saying, well, we're going to go through a procurement process. We don't know if CUPE applies. We'd like you to quote as if it doesn't. And then as and when we select a provider, we will go through the process of providing the information and just accepting that there might be caveats based on the TUPE requirements and of those individuals that might pop out. And then the final thing I would urge is when you release your tender, set a sensible clarification window so that people can read it, agree internally within their own organization what information they've got, what they're missing, what doesn't make sense to them, and allow them ask clarification questions, which quite rightfully needs to be shared across all organizations. But you will find that the market will look to lift the hood and fully understand the information, and will ask clarification questions, which can only help in them across the market giving you a better and more detailed response. A couple of sort of recommendations, if you like, to procurement departments that we see in the market that we would just urge that perhaps you avoid. One is that there are some very sensible accreditations out there that actually provide some sort of valid information, and I would urge you to use those. That if somebody is ISO 9001, quality standards, 27001 information security, or the 45,000, the occupational health and safety, they've already achieved certain levels of accreditation or standards to achieve those accreditations. And rather than repeating the information in asking the tender, that should be an automatic tick box that somebody is going to be up to those minimum standards. Similarly, CQOS, which always get this wrong, stands for Safe, Effective, Quality Occupational Health Standards, and has been in place now for over 10 years. And I think there are about 200 organizations already credited to CQOS, has already gone through a process of validating. And I think they have, 5 key areas. They've got business propriety, information governance, people, i.e. the people must be competent and appropriately governed, facilities, equipment, relationships with buyers, and I think relationships with workers as well as the 6th, actually. So there is an element that a provider will have had to go through to get CQOS accreditation, and that should give a reassurance that they're already there and you don't need to re-ask those questions. That should reduce your question requirements. Once again, in asking the questions, and I know procurement departments quite frequently will go to different departments within their own organization, putting their questions together. And I would just urge you try to reduce duplications. I see it in most tenders where you're asking the same question slightly differently in different lines, and you can just get a confusing response. So I would just urge a bit of caution on that. The big challenge I have, and I really do have sympathy here, is where procurement departments are trying to get comparable responses, and they're using, for example, Excel as that comparator worksheet that they can drop different responses into. Quite honestly, Excel is an absolute nightmare for a market to put together a sensible, intelligent, innovative response, squeeze it in. They can't use any graphics to show process flows or demonstrate platforms, etc. And I just don't think an organization gets the best view from the market by using it. Similarly, where you ask somebody to give a full detailed response and are saying, and do it in 400 words, all you're doing is you're going to end up with organizations giving the absolute minimum words, but they're not, you're just losing their ability for them to demonstrate what they can offer. And I think the organization buying the service is not going to see the best from the market. So I personally, I just don't think Excel is the right format for responding to detailed procurement services on how a professional service can operate. And I would urge against word limits, although I fully understand, what you don't want is War and Peace published from each organization, because if they are going to be there, put sensible word limits in. And I suppose a spin-off of that is, allow the graphics, allow people to show process flows. It's so much easier to do than just writing paragraphs of text of how service can work, and allow them to innovate that. Very easy to look rearwards and say, this is what we've had, this is what we want to procure. Once again, I would encourage you, look to the future, look what's coming down the line. and don't just duplicate what you've brought before. The world is constantly changing, technology is changing how we do things. The market is innovating, and encourage that change, the opportunity from that change. And a couple of contractual issues, we always see them, they pop up. Most occupational health providers will be a data controller, and just make sure the contract is looking at a controller to controller rather than a data processor, and making sure the contract is appropriate to service delivery, i.e. we're not delivering goods, we're delivering services, and therefore it just needs to be an appropriate contract. Key criteria to measure, and once again, this is, you know, how you score it, how you measure the output of this. Just a few thoughts from me personally. As I said, there are already accreditations being used, so the credibility, financial security of an organization and the accreditations they hold are a benchmark to me. The organizational structure and particular clinical strength, those that are employed by the organization, I think is really important. I mean, this is a clinical requirement you're buying, and therefore clinical strength must be by definition a really important factor that you measure. Their ability to resource, coming back to this is a challenging market, there's a limit of clinicians. And therefore that resource capability is very important. And, you know, good quality OH, however good your IT platform is, however good everything in the background, it's driven, it's a people business. So it's driven by the quality of its clinicians. And I think that should be an absolute essential measurement that one is trying to grade who the best provider for your organization it is. IT platforms, very important. They drive efficiency and how we all work. And there's really either they're built by the organization or there's off the shelf. And I guess the question then is, does it fit for what you need? And what's the level of bespoke ability that you can put in to personalize the platform to you as an organization? Coming back to the clinicians, governance, what support do they get? Do we train them? Do you develop them? How do you audit? How do you review their quality of work? I think would be something I would expect to be measured. We're increasingly seeing people asking, quite rightfully, around their social and environmental footprint, and I think that's an element of the scoring is going down that route. And then obviously, once you get into the detail, you know, are those services that you're looking for, are they very obvious, clear, practical? Do they fit what you need? And then, of course, cost is very important as well. So those are just some of the bullet points I think I would be, if I was a buyer, looking to score the organizations submitting bids to me. Just a couple more slides. Just some thoughts on processes and timelines. If you get the chance, rather than just launch tender, you know, why not set up some calls with some providers to get pre-market engagement, just to understand some of their ideas and thinking. It'll help you develop some of the service lines you want to pitch. So that sort of pre-market engagement, normally welcomed by the market because we can all come up with some ideas which we think are really important. Once you've submitted your tender, give a sensible timeline for clarifications. And I would urge at least 10 days, 10 working days, that is, so that the organization can review it and identify those questions. And likewise, you know, please give a sensible return time. Asking for, depending on the size of your organization, for somebody to return within a week just is impractical. And I also, a sympathy plea, you know, releasing a tender on the 20th of December and asking it back on the 5th of January, you know, like all organizations, there are obviously challenges over holiday periods. So we just ask for sensible periods of time. Be very clear, we would request on your evaluation criteria, how much is technical, how much is cost, and you know, be open and clear when you're in the market of what you're going to grade this on. How are you going to evaluate the scoring system? And the more you can give that, the more information it'll help the market in responding. I'm a strong believer that presentation's very important. It gives you the sort of culture of the organization when you get to see them and talk to them. What I would say is, I don't think you need to see everybody, because that can be quite an imposition on a buyer organization if you've got 6 organizations, let's say, responding. So you can shortlist it down to 2 or 3. But I would ask that you book time right at the beginning when you launch your tender process. Advise them of the dates of the presentations, because most organizations would like to bring one of their doctors, and the more or one of their clinicians or one of their senior team involved, and the more time we have to book their diaries up, the better. So book that up, and then obviously be clear on what the intention for the award date is. I do understand you can get slippage, but be clear on that, and then thereafter have a very sensible time post award for a lead-in, and certainly my recommended minimum is 12 weeks. I think depending on the complexity, certainly if CHUPI's involved, absolute minimum of a sort of 12-week implementation and launch would be my recommendations. And then really just as a final thing, I would ask, a lot of these tenders can be complex, a lot of time can be put into them. And I would just ask, even if an organization is not successful, in my experience, people want to learn why they're not being, and it's not a challenging conversation. They want to listen to you of why they haven't got their message across properly. So we would ask that you give time so that we can learn. All that will do is drive ongoing improvement. So that's those organizations that have not been successful, or indeed, even if they are successful, I'd like to know, what's scored particularly well. But then I would look to set up an implementation launch meeting, and even after it's launched, do a sort of review after the first quarter, perhaps. How's it gone? What's working? And what we're going to do. And then absolute final point, whatever you buy as part of that procurement exercise, in my mind, should not be in play the same in a year, 2 years' time. This ongoing program of improvement, we should be challenging you as clients as much as you're challenging us as suppliers to constantly improve programs. And the world of health is changing, as we've already seen, quite dramatically. And I think there will be ongoing innovations, not only technological, but ideas that come from organizations. So that's a sort of 40-minute quick run through of my thoughts as just one of the providers in the market, of what we see. I think as organizations, as I say, there will be an increasing need to help you support your employees as they, some of them become challenged with health issues. And I know the market's, very keen to help, but it's, if it's procured right, I think it is a very valuable and high impactful service. Hopefully that's helpful, Mike. I'll stop and see if we have any questions. You're on mute, Mike, by the way.
That's what I was saying. Was thank you very much, Keith. Very comprehensive talk, and I like the way that it was aimed at buyers of occupational health as well as at providers. That's quite important, because each side has different views very often. We've got good 20 minutes now for questions and comments. The only trouble I got is that I think, Nick, you ought to manage that, because I can't see everyone on my screen, I'm afraid, at the moment.
No, that's fine. We've got some questions. Marjorie Fish says, is there a template to use rather than using an Excel to shortlist? So do you use any templates?
I mean, I think one can easily develop a Word template, answering some of the questions that I've suggested you perhaps score it as. I haven't seen a sort of market template as such, but ultimately, because I think each organization has their own specific requirements, but one could easily develop one. And there are certain core questions. IT system, is it in-house, is it external, is it bespokeable, etc., one could drop in. It's really, you know, my plea against Excel is it's just impossible to put it in a format that's easy to read and certainly doesn't give the opportunity for the market to present it's sort of best foot.
Another question about software handover at the end of a contract. Who owns the data? So it's more of a technical issue, but this is often a really big issue in terms of handoff between one data provider or IT company as they support occupational health company who's supporting another company to then move over. So any comments on that transition?
Yeah, I mean, I think data is obviously so important. I think there's a couple of issues here. Is one is the actual individual medical record is actually owned by the individual. It's not owned by the organization. And hence, you know, there is a transfer of medical records process that providers can handle and will support you on. And that's all about giving an opt-out for employees, but it will then go from one occupational health provider to another in a secure format, be it hard copy or electronic records. So, of course, the organization will have data, and that can be provided on its sort of compliance with health risks, the health surveillance, statutory records, or indeed the outcome reports that will have been provided during its relationship. You know, that sort of data will have flowed during the contract. But the actual individual medical records themselves don't go to an organization because they are personal medical records, and you know, an occupational health provider will hold those in a secure format and will transfer them to any new provider. But any new provider will help you through that process. I think, you know, we're all adept. We've all won and lost accounts in our commercial life, and there are very good protocols. We have to comply with the protection of medical records, and you know, we will follow that protocol to make sure that that occurs correctly.
I think that one can add to that that it's not unusual to have a fee for doing that. So if you've got lots of medical records to transfer at some point, it is quite routine in our industry that there's a fee for doing that.
Thank you very much. Anyone want to come off mute and pose a question directly? Nice to see you all, some people, occupational health people, but it's particularly for occupational people who want to procure and use occupational health. And you can see both COPA and SOM have a way of finding out, you know, what occupational providers exist, and there's also something on commissioning occupational health. Any questions? Anna's here from COPA, which is good to see.
I mean, if I can just comment on it, because I know, well, there's two areas. Obviously, there's CQOS has got all its registered members, but I know COPA have a very good facility where you can find a provider. I think they call it, and you know, you go to their website and you just follow the link, and you can put in what you want, and it'll take you from there. So there are different ways to get it.
Yes, I haven't introduced myself. I'm a director of COPA. I'm also a life president, because I founded it. So you're absolutely right, Keith. One of the major things that COPA does is give people information on what providers are around, and every inquiry is then sent out to all the members. So all the providers who are members of COPA get a list of people who want to buy occupational health, and it allows the COPA to make sure that the whole industry, as best as possible, gets those inquiries.
Okay, Marjorie, is it the case that there is a transfer of OH records process under the GMC?
Yeah, I mean, effectively it is. They are the GMC guidelines that we all fall under, that sort of process, and that's the sort of recommended process. And as I said, my only message is sometimes you see people saying, "Oh, we want the records need to be transferred back." We can't do that. We have to because they're personal medical records, we have to transfer them to a secure medical records organization, which tends to be another organization if the tender has appointed somebody else. But as I said, it's not a daunting process. We, as I said, all of us in the industry have worked through it before. It's a matter of just understanding what records they are. Are they hard copy? Are they electronic records? And then there's a sort of protocol, which is normally to give an opt-out period. And most organizations will give you a set of words to use to your employees, just advising them that there is a change of your occupational health provider. And if anybody doesn't want their records transferred, they should notify it. So it can operate on an opt-out rather than an opt-in basis. And once a sensible period has gone past, then that transfer can occur. And those employees that don't want to transfer, which once again is very seldom that occurs, but those records would then be transferred back to the individual.
Correct.
Thank you very much, Keith. So the comment is about how do we get these messages to employees? Often it's the cost. I mean, it's interesting. I was looking at a government document last year, I think, on innovation, occupational health, and saying cost was an issue. Innovation occurs, but it shouldn't be about cost. And you rightly focus on quality and CQOS. So this is a difficult marketplace situation, isn't it?
Yeah, I mean, there's two messages I'd say that, and I fully understand. Of course, cost is a really key driver, and will be an essential scoring element of it. But I come back to what this service is. It's a professional medical advisory service, and you wouldn't appoint the cheapest lawyers just because they're the cheapest lawyers to provide you legal advice. And I would urge again, if you're looking for high quality professional advice, then cost needs to be an element, but it's not, to me, should never be the largest element by any shape or means. It's the cost of having people off work far exceeds the cost of occupational health. So on the whole, I think most employers get that, and I certainly I know from the tenders we look at, we sort of will take our decision on whether it's a totally cost-driven exercise or not, and most actually are reasonably sensible on it. But it's sort of a message. If you understand what the service is, what it's trying to do, and more importantly, the impact of what a good occupational health service can give you in not only helping your people that have a potential medical issue, but also on the health and well-being side, preventing a lot of this stuff, then really cost just drops down the order of priority.
Any other questions or comments? People welcome to come off mute, introduce yourself. I think we've covered a lot of ground in terms of the IT side, the transfer of records, the need for employers to choose, not necessarily on cost. Quality is important. Template for shortlisting. Anything else? Well, look, this will be recorded. I think, unless there's any other questions, I might hand it back to you, Mike, to sum it up, and then we'll stop recording. This recording will be shared for other people to use when they're thinking about. So over to you, Mike.
Yes, thank you very much, Nick. I'm sorry about my inability to see who was asking questions, but on the iPad, I don't have enough room to see all the 65, 70 people we've had. Yes, I think it's been a useful session. I agree with everything Keith has said. It's important, and I think every reasonable sized firm has, in terms of providers, has a specialist in procurement and in liaising with potential new customers. It does take quite a lot of time. I think, Keith, you'd agree that going to see the potential client is quite important. It's quite difficult to do decent sized work without actually meeting, discussing, asking what their requirements are, what they want, what they're looking for. Also, as you said, teaching, you know, actually explaining to them what it is we do in our industry. And they don't all know. I mean, that's the issue. If they've not had occupational health before. So, but I think it's been a very useful session. I'm grateful for everyone coming to listen. And if there are any questions or thoughts of afterwards, I'm sure they can be applied to the SOM or COPA, and we'll do our best to answer. In the meantime, thank you very much, Keith, for your hard work that you've put in. Well done.